So diabetic complications, they're our last section. So diabetic complications can be acute or they can be chronic. And you can be in the hospital for either one, but and oftentimes when our patients are in the hospital, they might complain of like retinopathy, nephropathy, or neuropathies and gastroparesis. But when do they end up in the hospital? When they have the amputation, they have a foot that doesn't work, like the one on the top right there. That's not going to work good. So we have foot ulcers that can percolate and gangrenate. I don't know if that's a word or not, but it can that can lead to severe infection. Okay, but acute complications, that's where we're going to start first. Those ones can be hypoglycemia or hyperglycemia. Hypoglycemia is very, very deadly and cause permanent neuro damage. And these DKA and HHS are acute complications that are deadly as well, right? But usually patients seek out care, and that's the reason we want to try to get them out of that hyperglycemic state as safely as possible. Okay, there are skin manifestations you can see in diabetics, like darker armpits, darker skin folds, darker neck folds, that those are signs of diabetes as well. So low sugar. So when your sugar's low, why did it happen? Why did you get a hypoglycemia? What are the causes and what are the symptoms of hypoglycemia? So it's very, very common in the hospital setting, and it's also very, very reversible. It's like the movies. You give the treatment and they wake up. What happened, right? So it's unlike other things, like when someone's hypotensive and you try to fix their blood pressure, it might take them a while to bounce back, right? But this will fix them right away. So what causes it? So you can have hypoglycemia at home or you can have hypoglycemia in the hospital. So the first section there is causes in the hospital. What causes it is someone giving insulin, obviously. So I gave insulin and then I forgot, oh, they're going to an EGD today. Oh, they're going for an MRI where they have to be NPO. Well, you can't take the insulin right back. You can't massage it out, right? It's already given, right? So you have to be conscious of that. Are they NPO? Because if they're NPO and they got insulin, that's going to cause a hypoglycemia event, right? Also, you're giving the insulin, you're doing the same insulin they've been having for 3 to 4 days, and all of a sudden the steroids were changed in half. Well, shoot, what do steroids do? They raise the blood sugar. How do you know a steroid was changed? Well, you know the names, methylprednisolone, prednisone, hydrocortisone. These are all steroids that raise the blood sugar. So if I reduce those, now I'm at risk for hypo or hyperglycemia. Hypoglycemia. What if all of a sudden they stop eating because they had a stroke and now they're in a different unit and they got their Lantus or their long-acting insulin last night, right? And now the morning time they're not eating. Well, now you're at risk for hypoglycemia, right? If they are NPO, they do change status, right? They're going for a procedure, they can't eat anymore. We want to give them D5 water. That's usually enough to prevent them from going into hypoglycemia. Okay, and then glycogen loss, that can happen in severe disease, like severe infection. We lose all of our glycogen stores. Severe liver disease, we can't make glucose. That can happen as well. But at home, what would cause someone at home to have hypoglycemia? Maybe they started a new medication and they don't know about it. Like they weren't taught right by a nurse, an RN or something that didn't know about sulfonylureas. Hey, you're being started on sulfonylureas. Make sure you take this with food. If you don't, you're going to have hypoglycemia, right? So encourage more frequent blood glucose checks. If they are getting hypoglycemic at home, we do teach them the symptoms of hypoglycemia so that they can seek out care and know what to do. Okay, so the symptoms of hypoglycemia are there on the right as well. Right, you get SNS symptoms as a side effect. And then at bottom left there, they get extremely diaphoretic. That's usually like a key. My patient's like soaking wet. What the heck happened? The first some things a seasoned nurse can ask you is, did you check the blood sugar? Because that's probably what might be going on. Okay. So then decreased food intake at home while still taking insulin. Well, they didn't follow the instructions. So that's obviously, if you're taking insulin and you're not eating, you could be at risk for hypoglycemia. This one has a little asterisk on it because maybe they're not eating because they have an infection, and an infection can cause hyperglycemia. So the moral of the story is still check your sugar. All right, and there's what are called sick day rules that we have to teach them. So that's coming up as far as with hyperglycemia. You teach them sick day rules to make sure they're checking their sugar frequently, checking their ketones frequently, and going to the hospital if their sugar is not resolved and the ketones keep going up. All right, they could be going to kidney failure at home, like they're not taking care of themselves, and kidney failure. You're not getting rid of stuff, so you're not getting rid of insulin. So the insulin is going to stick around, and you can get hypoglycemic. They didn't follow the exercise rules that we gave them. All right, they just took the insulin and went for a jog, or went and they waited an hour, waited 2 hours because their friend couldn't get a ride. They had an Uber over there. They got a flat tire. Right, they got 2 flat tires for the math exam last week. So then they all came over and they were late, right? And now they're now he's out jogging and he passes out, right? He's hypoglycemic. All right, alcohol can do it, or they're not eating enough food. Alcohol will inhibit glycogen formation. And again, the symptoms are an SNS response. All right, what's an SNS response? It's heart rate elevation, tachycardia, tachypnea, diaphoresis. They'll have pupil dilation and such, but they are all these things are taking effect, and that's going to cause a extreme diaphoresis, like I pointed out. All right, the other thing they're going to have are the hungry. It's like, oh, I thought that the 3 Ps and polyphagia was hyperglycemia. Well, the cells are still starved, right? The cells are starved in hyperglycemia because they couldn't get the glucose, and here they're starved. So you're hungry in both hyperglycemia and hypoglycemia. All right, what else? So when your sugar gets super low, you get what are called neuroglycopenic symptoms. And what does that mean? I have low sugar to my brain, and my brain function doesn't work good. And it has symptoms that mimic a stroke. So whenever someone comes with a stroke to the hospital, they always say, what's the blood sugar? Because it could be the blood sugar that's causing them to act with these stroke-like symptoms. Okay, so it's a priority. When we talk about strokes as well, that those are mimics for strokes. One of the most common mimics for strokes, because diabetes is so common, is it could just be hypoglycemia. And you can turn that around right there. Otherwise, with a stroke, there's more steps involved. Okay, but then after that, they're going to get altered, they're going to get seizure activity, they're going to get comatose, and it's not great after that point. Okay, so sugar low, right? You're going to have, so cold and clammy, you need to have some candy. And the next step when we talk about hyperglycemia is they're going to have all the symptoms we talked about before, the 3 Ps and dehydration, right? So hot and dry, the sugar's high. What happened? My internet connection is unstable. Cool. All right. So, anyways, hypoglycemia treatment. How do we fix someone? We say we recognize they have hypoglycemia. What are some symptoms of hypoglycemia again? The cool, clammy, very, very sweaty, very, very tachycardic, tachypnic. All right. They might be altered. They might have focal neurodeficits. And what's a focal neurodeficit? That means they can't talk good, they can't move good, they have a problem specifically to their, they are unable to do a certain task, right? They can't remember their name, they can't talk, right? They're mumbling. So what do, right? So if they're awake and able to swallow, eat something, right? So take some sugar, right? So if you give some fast-acting carbs that are going to raise the sugar right away. Usually it's 15 grams of carbs, right? So you give some lifesavers to save their life. You give some skim milk, not fat milk, because fat milk has fat, and fat's going to decrease the absorption of sugar. Or we have glucose gels. Usually the glucose gels have different packaging inserts. It's not the same across all glucose gels, unfortunately. Right? So if they're able to take medication or food by mouth, give them food. Right? That's the key thing. And one of the things we teach diabetics is make sure you have these things in your pocket. So if you do get hypoglycemic, you just eat some. Right? What if they're NPO? All right, so really this lends itself to an algorithm as well, because otherwise you get super confused about which one's which. Because there's like two things. If 2 things meet criteria, you do this. If 1 thing is there, you do this, right? So first thing is, are you able to take PO? That's the easiest question. If you're able to take PO, do PO stuff, right? Now if they're NPO, now it divides, do they have an IV or not, right? If they don't have an IV, what do? Start an IV. But the other thing is you're going to do in the meantime, they're hard stick, they're super sweaty, you're slipping around, right? You're slipping on the floor. It's like a comedy of errors, right? So what do then? You stab them with what? Intramuscular glucagon, right? Does glucagon make the glucose go gone? No, unfortunately. Glucagon makes the glucose go up. Right? So glucagon is it's our natural hormone that we have that's going to do its thing. It's going to be given IM, and it's going to raise the blood sugar. All right, so the other side effect, I should say, of glucagon is nausea, vomiting. So like every medication has nausea, vomiting, so why do I bring it up? Because it causes like nausea, vomiting. It's going to make them projectile vomit. So you want to turn them on their side so they don't aspirate. and let them vomit. Okay, and then grab some alcohol swabs in the meantime. Okay, so that's the piece when you give glucagon, it's given IM, and they have a very high risk of vomiting. All right, so what about you have their NPO and you have an IV? Well, that's easy. Give IV glucose, right? So you give IV dextrose. And the different hospitals have different recommendations. Do you give half an amp or full amp? And it depends like if they're awake or not awake, right? So there's different criteria there, right? So the key thing though is also, how do you know they're hypoglycemic? You check the sugar, and it was less than what? Less than 70. Sometimes less than 65, sometimes less than 60, depends on who the lab director is that year. But 70 usually is pretty well accepted, less than 70. And then you do the things, right? You say, hey, can you eat? If you can eat, eat. If you have an IV, if you have an IV, give IV, right? If you have no IV and you can't eat, what do? Give IM glucagon, okay? So then you keep checking the sugar in 15 minutes to make sure that it is sustained, right? If your sugar, you could dip again because they could have got some insulin that's on board. You're fighting an uphill battle. So at that point, you got to start some IV fluids. What IV fluids would you start? Usually D5 water. Depends how bad their hypoglycemia is. If it's really persistently low, you might even upgrade to D10. Okay, so giving 15 grams of carbs is important. If that doesn't work, you give glucose or glucagon, IV or IM. Okay, so that's the idea with how to fix hypoglycemia.
These pretzels are making me thirsty.
Kramer, what happened here?
I don't know. What should we do? We called an ambulance. Does anyone know first aid?
Shouldn't you do something with the extremities?
What extremities?
What's an extremity?
Well, you raise the feet, get blood to the head.
Oh, you raise the head, you get blood to the feet.
Okay, what about a cold compress? They always do that.
I don't have a washcloth.
Well, use a paper
You
towel.
can't put a paper towel on his head.
What about a big sponge?
How are you going to hold it on you?
Use a belt.
No. It'll drip all over him.
Should we walk him around?
Yeah.
I've seen him do that.
No, that's for a drug overdose.
Maybe that's what he's got.
No, Kramer, I just had lunch with him. He didn't leave the table.
Well, he could have dropped acid when you weren't looking.
He is not a drug addict.
Hey, you know what? Maybe he's a diabetic. He might just need a cookie or something.
A cookie?
Can you give him a cookie?
How's he gonna chew it?
We'll move his teeth. It happened to my uncle. The sugar revived him.
Careful, you're getting crumbs all over him.
I got him chewing, but I don't think he's gonna swallow.
All right, you know what? Let's put a few cookies in a blender and he could drink it.
Cookies don't liquefy.
Yes, they do. You can liquefy a cookie.
Well, then I'll get a blender.
What blender? I don't have a blender.
You got a blender?
I would know if I had a blender.
Where's the ambulance?
All right, so is that patient able to take PO? No. So do they have an IV? No. So what do they need? They need glucagon, right? If they have hypoglycemia. All right, so hyperglycemia, you have high sugars. So the sugar is super high. What caused that to happen? So there's stress is a big one. So they have adrenaline circulating around. They have cortisol, right? So 12% of patients in the hospital get really, really high sugar. It doesn't mean they're diabetic, but they could have really, really high sugars, right? A diabetic is for sure going to have high sugars when they're in the hospital itself, right? Especially in the ICU, right? And there's certain medications we give, like steroids, that's going to raise the sugars. They should have insulin to counteract that, right? To keep the sugar under control. Why does it matter? Why keep the who cares if the sugar's 250, 300, 350? What's the whole purpose of that, right? So the reason is because our white blood cells don't work when the sugar's over 200. So do you need white blood cells to fight an infection or to fight something, right? You need to have those white blood cells functional. If you don't, then you're going to be in the hospital for longer, right? You might not even survive the hospital stay, right? So if you're at home and you have your sugar is high and you're sick, right? You should be checking your sugar so you know that your sugar is high. And there's sick day rules to make sure that they're not getting to the point of diabetic ketoacidosis, right? So DKA results when you have ketones, right? So they should be checking their ketones. If they're small, it's okay, but if it's starting getting a larger and larger amount of ketones, they really need to seek 911, right? And also the sugar is not getting fixed, right? The sugar is 275, sugar is 300, 400. It's time to come to the hospital at that point. So it's important they know their sick day rules, right? So what do they do with their sugar? They got to check it every 2 to 4 hours. What do they do with their insulin? Should they take it? It's like, but I'm not eating. but your sugar is 250. You have to take your insulin, right? So carbs, they should have something available. If they can't eat, they should eat something like bone broth or something that's low, that's not going to make them super sick, like super bloated, I guess, right? And then ketones, they should check their ketones, because if those start rising, that's a sign of diabetic ketoacidosis, right? So then iatrogenic, so that means that we caused this problem. It's our fault. They're hyperglycemic, right? We forgot there's dextrose in the IV fluids. That's a problem. We forgot that they have tube feeding going, and we're still giving IV fluids also. Tube feeding has calories in it. And then TPN, that has a lot of dextrose in it. How much dextrose does TPN have? Has about 20% dextrose, D20%, right? Needs a central line. So D20 is usually found in TPN. So if you take away all that D20, right, and your body's cooking away, throwing a whole bunch of insulin in your bloodstream, you take away the D20 infusion, what's going to happen now? You're going to get hypoglycemic. So in the meantime, whenever TPN stops, we should be starting D10. And then Dawn phenomenon, and these guys, this is usually, and Samoji effect, that's usually a prescriber error. It's usually a prescriber using NPH is what causes these errors right here. It's usually they didn't give enough NPH, or they gave too much NPH. That's a problem that usually results from inadequate prescriptions or failure to monitor. All right, and then what are signs of hyperglycemia? It's just the 3 Ps and all the things we already talked about, right? How do you fix it? Give insulin. So we increase how much sub-Q they're getting. Sometimes it doesn't work. Sometimes their sub-Q tissue doesn't even absorb insulin because they're have a super low blood pressure, and they're rerouting blood away from their skin, away from their sub-Q tissue. But and we may need to have IV insulin. What's the only IV insulin? Is regular insulin. What are the complications of hyperglycemia? Is usually the treatment. We overdid it, we didn't recognize it. But the other complications are DKA and HHS, which we're talking about next. All right, so DKA, how does DKA work? So diabetic ketoacidosis is too much ketones. And remember, 2 out of 3 of our ketones are acids there. So you can see the bottom left there, you got our beta hydroxybutyric acid, you got our acetoacetic acid, and we have our fruit. All right, so our fruit is just our ketones, right? And you can actually smell that ketones on the breath as they're breathing in the room. They're breathing super fast. Why are they breathing fast? Because they have acidosis. Acidosis is a low pH, which low pH triggers the SNS response, and you're going to be breathing fast, right? So why does ketoacidosis happen? So ketoacidosis happens from the breakdown of lipids, right? So the brain needs to eat ketones. It won't eat glycerol and fatty acids and amino acids. It only wants to eat glucose or ketones. So our body obliges and makes ketones for it, right? And how do you make ketones? The only way you make ketones is when you have an absence of insulin. If you have insulin, you're not going to make a lot of ketones, right? So it's basically insulin. When insulin is present, ketones don't get made, right? Or they might give it a small amount. But basically, if you have insulin, you're not going to go into DKA. Okay, so we have this ketones building up. In a type 1 diabetic, do they make insulin? No. So they're at high risk of DKA. All right. So what causes DKA? It's usually the eyes. All right. So the bottom left there, we kind of highlighted them. So you have different eyes. They have an infection of some sort. An infection causes, it's cortisol to get released, epinephrine to get released. Now we have hyperglycemia, right? And all this, and then your body can try to release insulin, but it can't. So then you go into ketosis, right? So then incredible stresses. So you have an MI, an infant. It can happen in mothers. Ischemia, steroids can do it. Too much steroids can cause someone to go into DKA. And we got insulin non-compliance. It's a very, very popular one, right? Because insulin is incredibly expensive, so it's understandable. And also they might not be, might be able to afford it. They don't like how many times they have to check their sugars. So that can do it, as well as lifestyle. They're not abiding by our diet and exercise recommendations, so they are going to put themselves into DKA. And then a really popular one is a new onset diabetic, right? Or you might be thinking, can type 2 diabetics get DKA? They can. It's not common, but they can once they've exhausted all their insulin, right? Remember, the beta cells are working overtime in type 2 diabetes. They're producing and producing and producing, and then eventually they can just exhaust out. And now they don't produce insulin anymore, and it's going to then you can put them in the DKA. They're hyperglycemic, and why they form ketones? Because there was no insulin. Insulin is the off switch for producing ketones. If you give someone insulin, right, they're going to stop producing ketones. So what's the treatment for DKA? Give insulin, right? So what are your symptoms of DKA? Symptoms and diagnostic tests. So your symptoms are, you have as DKA, right? So D, you have symptoms of diabetes, which is hyperglycemia. What are those? Those are your 3 Ps, right? Polyphagia, polydipsia, polyuria. And usually the sugar is high. They have hyperglycemia. It's usually more than 250, right? And you're going to get SNS symptoms from all this dehydration that results from which one of those Ps causes dehydration? The glucosuria, the polyuria. Okay, and then again, the water is going to draw, the water is going to follow the glucose into the toilet, right? The other piece of this is you want to be able to differentiate DKA and the other hyperglycemic complication of HHS, right? So one of them has a normal sodium or even a low sodium, and one of them has a super high sodium. You think if I'm dehydrated, would my sodium be high? Well, that's only HHS. In DKA, these guys can drink water, right? These guys are able to drink water, so their sodium level actually is dilute. They actually have a low sodium, all right? And also all that glucose that's all in the serum, it's pulling water from the tissues. Their whole body is super dehydrated, but all that water is coming from the tissues, and also they're drinking water. And yes, they're peeing a lot, but they're drinking a lot, so their sodium is actually diluted out. They have a low sodium, if anything. And then another K stands for ketones, right? So they're going to have ketones present either in the urine or in the blood, right? We can measure both. So they have ketones in the urine or blood. That's going to clue you in that you have diabetic ketoacidosis. So what else? So we got they also have the fruity breath from the ketones that are being blown off. That's one way to get rid of ketones, is to exhale them through your lungs, right? And then K for potassium. Potassium is usually on the high side. Why is it on the high side? Because we have acidosis. Acidosis causes a rise in potassium, right? But they are also peeing out potassium. So really their total body potassium is very, very low. So we have to replace potassium on these guys when their K actually gets less than 5. So you're like, why are they getting potassium? I thought they're acidotic. Well, they were peeing out potassium, and the K was just kind of it was going inside the bloodstream because they're acidotic. They're super acidotic, and what does your body do when you're acidotic? It's going to kind of swap, right? It's going to maintain pH. So the hydro ions are going to go where? You know, all these hydro ions build up because the ketones are going to go into the cells in exchange for potassium. And then you're going to pee out the potassium, and then more hydrogen is going to exchange. So your total body potassium is actually very low. And we mentioned acidosis, technically less than 7.30. I'm not sure why they can't do 7.35 to make everybody's day much easier. And they also have a high anion gap metabolic acidosis because you're adding all these acids to the equation, right? So in the bottom left there, you're adding all these acids, these ketones, those 2 out of 3 ketones are acids. You're adding them there, and that's going to increase your anion gap. All right, so you can measure that with the chemistry. All you need on the chemistry is a sodium, a chloride, and the bicarb, which is your CO2, right? And then you can measure how bad their DKA is. How you know they're out of DKA? They're not making Ks anymore. They're not making ketones anymore, right? Yes, you could measure whether ketones are present, but the more you can measure exactly how many there are. They had 36 before, and now we have 12. 12 is normal as far as our anions go. Our anion gap goes. All right, so what are diagnostic tests you want to make sure we're monitoring are the BMP, because the K can get dangerously low. Why would the K get dangerously low on someone that is getting treated for a DKA? You're giving insulin, right? Insulin puts K inside the cells, right? And also we know their total body potassium is low because they're peeing out potassium for a while, right? ABG can be done to make sure they're getting better. And then, of course, figure out the underlying cause. Do they have an infection? Where is the infection at? Okay. Yes?
Why does it say hyperglycemia? Did you just say hypo?
So they are hyperglycemia. The K is high in the bloodstream, but the total body potassium is actually low. So Yeah, because all the K was being peed out, and all the K is being brought from the cells, from their storage, and put back into the bloodstream. All right, so what's the treatment for DKA? It's FIE, all right? So Fee, Fi, Fo, Fum is F for fluids, I for insulin, E for electrolytes. Why fluids? They are extremely dehydrated, right? Why insulin? That's going to turn off ketosis. Why electrolytes? Well, because they're peeing out potassium, and we want to make sure we replace that. They're also using a whole bunch of energy, like phosphorus, so we've got to replace phosphorus. We want to replace magnesium as well, because if the magnesium is responsible for putting those electrolytes back in the bloodstream, right? Working on the kidney protein transporters. So that's the idea with the major treatment is FIE, fluids, insulin, electrolytes, and an incredible amount of fluids, right? So there are 10 mLs per kilo per hour, up to 50 mLs per kilo per hour, or total in 4 hours. So if you weigh 100 kilos, you're getting 5 liters of fluid, right? So complications with the K, you can get cerebral edema if you bring down the sugar too fast. So the sugar is like 1200 and you bring it down to 200 the next hour. That's not good, right? That's way too fast, because remember, glucose is very, very osmotically active, and if you bring it down way too fast, right, now the space is open, and then now all the water is going to want to go into the brain, right? If all the sugar left, right, now you have a dilute bloodstream that's full of water, and water goes where there's a lot of water to where there's a little bit of water. Where's a little bit of water? The brain, right? So you get really, really serious complication of acute cerebral edema if you bring down the sugar too fast. So we bring down the sugar about 50 to 100 points per hour. And again, hyperkalemia can happen if you're not watching it, right? If the acidosis is getting worse, if you're not doing the basic metabolic panel, the chemistry every 4 hours, the K can get really, really high, and you can get hyperkalemia. And how do you know you have hyperkalemia? We have what? What are these things here? These are peaked T waves. You can imagine if you just grab this with your hand right here. So if this is you, and you grab this T wave and you pull it, right? Those are all your symptoms, your EKG findings for hyperkalemia, right? So the QT gets prolonged, the PR gets prolonged, the QRS gets prolonged, and it gets all the way into a sine wave or to asystole. All right, so the alternative to DKA is HHS. So HHS is what it stands for. So HHS stands for hyperglycemic. So they're hyperglycemic. Hyperosmolar, so they're what? Dehydrated or overhydrated? Dehydrated. Hyperosmolar just means super concentrated syndrome. And it used to be called HINK or HONK, which made more sense because the NK means non-ketotic. It means there's not ketones present. They're not acidotic in this patient in HHS. So HHS is just extremely high blood sugars. They have really, really high blood sugars, and how is it different from DKA? It's because they don't have ketones, and yes, they're not acidotic, but usually it's someone who can't reach a water source, right? So like a DKA patient can reach a water source and keep themselves hydrated and surviving, right? But someone with HHS is someone like dementia, someone who's debilitated, who's mentally incapacitated, and they can't drink water. They're sitting there in a nursing home, or they're sitting there on the 5th floor, and no one's paying attention, right? And their glucose is going higher and higher and higher and higher, and they're peeing out and peeing out and peeing out and peeing out, and they get very, very dehydrated because they don't have access to water. That's 9 times out of 10, that's usually the cause of HHS. The other piece with HHS is it's only type 2 diabetics. It's not type 1 diabetics. It's literally impossible for type 1 diabetic to develop HHS, because when HHS happens, it's usually because you have some insulin functioning. The insulin is preventing ketosis, right? When insulin's gone, you form ketones. When insulin is there, you don't form ketones. So who has insulin? Type 2 diabetics. Who doesn't have insulin? Type 1 diabetics. So it's impossible for type 1 diabetics to get HHS. All right? The mortality is extremely high. It's like 60%, which is ridiculous. DKA is like 5%, which is still really, really bad, right? So if you have 30 people here, 5% means like 2 of you are walking out today, right? That's if all of you got DKA now, right? Whereas 60% means more than half of you, right? 17 of you are dying if you had HHS now, right? So that's an incredibly high mortality. Okay, so it's extreme hyperglycemia, right? There's something triggering it, just the same things that triggered DKA, the same things, right? They didn't get their insulin, they have an infection, something's going on to make them present with HHS. All right, so what are the symptoms? It's just hyperglycemia. They got the 3 Ps, and they got profound hyperglycemia. It's usually greater than 600, and extreme dehydration. They definitely have an SNS response, definitely dehydrated, and they definitely have a high sodium as a difference between DKA and HHS. So you want to be able to differentiate these guys, because this looks like a really good SATA question. All right, so which one? The patient has HHS, what do you expect? Patient has DKA, what do you expect? What do you do for treatment? What do you do for nurse interventions, right? What do you think the causes might be? Okay, so do they have acidosis in HHS? No, there's no, it used to be called non-ketotic, but also you're not producing ketones, and ketones are the way you got acids, right? So the sodium is super high, serum osmo is super high, okay? So the treatment is the same, which is nice. It's fluid, insulin, electrolytes. It's good. They're extremely dehydrated, so they can get up to 12 liters of fluid compared to our DKA patients that only got like 4 to 6 liters. So they get extreme amount of fluid replacement. They get insulin as well, IV, and they get electrolytes. Okay, so they've been peeing out potassium. They're probably gonna have a lower potassium. They're not acidotic, but they're gonna have the same treatment as HHS. And usually you're done with HHS when they're more alert, right? When you have DKA, you're done with DKA when the anion gap is closed, right? When it's come back down to 12. All right, so our last 2 slides, I believe, are the chronic complications. So we had acute complications that end you up in the hospital pretty much almost all the time. When you have DKA and HHS, you can't just tough it out, right? You have to present to the hospital and get it fixed with IV insulin. There are some sub-Q insulin strategies, but really they need IV insulin. They need a whole bunch of fluid, right? Up to like 4 to 6 liters of fluid at some time for our DKAs at least. All right. So chronic complications, why do these result? They result from glycosylation. What is glycosylation? That is rock candy, right? So rock candy is crystallizing across all the vessels. It's crystallizing across all the nerves, right? And that's causing nerve damage, right? Or neuropathy. It's also causing the vascular damage or vasculopathies, right? So we can separate in macrovascular and microvascular. The big vessels, like the big vessels to the brain, big vessels to the heart. The heart vessels aren't that big, but we have these big vessels to your legs or your arms. Usually the legs are the most common. So you get peripheral arterial disease, you get CVA, CAD. So diabetes is an important cause of these diseases. And we'll be talking about each one of these this semester. So CAD we talk about next week, right? And CVA we'll talk about in 2 weeks. And PAD I think we talk about in 2 weeks as well, or 3 weeks, whatever. But all these, an important cause for each one of these is diabetes, right? It's crystallizing. It's called hyaline arteriosclerosis, which is just a fancy word for crystallizing, and it looks glass-like, right? So it's a glass-like crystallization all over the vessels, and the vessels don't work good. And because they don't work good, they're like fragile, and now atheromas can develop, and now you have ASCVD and diabetes, and it's a whole downward spiral from there. Okay. As far as the treatments for all these things and the symptoms, these will come with when we go through all the different disease processes. Don't worry about what all the symptoms of CAD are, all the symptoms of CKD are. We'll talk about those coming weeks. But you do need to know prevention. There's a really good one to know. It's a really good SATA question. What should you do to prevent a patient from getting further complications, right? They should check their A1C, make sure that's good. What's a good A1C for a diabetic? Less than 7%. They should check their lipid profile. And really, lipid profile is more of a final question where you say, make sure your lipids are this, right? And we'll talk about lipids next week, right? But about hypertension, they got to make sure their blood pressure is good. And we'll talk about good blood pressures in a couple weeks. But these are all macrovascular changes. They get hypertension, and hypertension causes CAD, and that's all interrelated, okay? So then we have microvascular problems. We have CKD, the glomerulus literally gets fried or crystallized, and it doesn't work well. And then we get retinopathy, vessels to our eyeballs, our retina start deteriorating over time, and we can then do what are called fundoscopic exams, not a fundus like an OB, but a fundoscopic exam where you're looking at the back of the eyeball and you're assessing do they have diabetic changes, okay? So that should be done yearly, okay? So yearly over here, yearly fundoscopic exam. For CKD, they should be checking to see if albumin is poking its way through, if the vasculature is causing is breaking down and the glomerulus is breaking down and allowing proteins through, that's a sign of kidney disease, right? And erectile dysfunction is not a serious complication, but it's a complication that requires a lot of importance to certain populations. And that's usually the first sign of coronary artery disease. The first sign of a stroke is the erectile dysfunction happens first. The vessels are about the same size. All right, and then we have osmotic damage. Right, so usually when the glucose makes its way into cells, it's broken down. Right, and but these three cells here don't break it down well. So because they can't break it down, those cells puff up, right? Because where glucose goes, water goes. So all the water infiltrates into the cataracts. It infiltrates into the back of the retina and causes blindness. It infiltrates into the glomerulus and causes the glomerulus to break down. It infiltrates into the nerves, into the Schwann cells around the nerves and causes the nerves to break down. That's in addition to the inadequate blood flow that they get because of the microvascular changes. All right, so then neuropathies. So neuropathies happen when you lose that nerve function because the myelin sheath's breaking down, and also you lose the vascular supply because the vessels are getting so caked over with rock candy that nothing can get through. All right, so you can see I thought I had a good picture there. This middle one here, you can see all these nerves are getting broken down here, and the vessel's getting so tight, and it's unable to get blood flow to the extremities and to the gut, for instance, for the stomach. It causes gastroparesis, which is very, very common complaint, is they're feeling full all the time and they're throwing up all the time. So we have some medications we can hit them up with. These guys prolong the what? Prolong the QT. All right, so these guys are increasing QTC. Erectile dysfunction is not only vascular but also nerve related. And they can get what's called orthostatic hypertension. The blood pressure might be higher when they get up. The urinary retention causing UTIs, and they got sensory nerve problems where the nerves don't they don't not only have the autonomic breakdown, but also have the sensory nerves that don't work. All right, so since they get peripheral neuropathy, it has like a stocking glove appearance where their hands really hurt or their feet really hurt. All right, that's until the nerve just completely dies off and they don't feel anything at all. Right? They don't feel anything at all, and then they step on a rock, they step on something that's going to cause an ulcer to form. And they have diabetes, and the sugar's more than 200. Do white blood cells work? No. So they have slow wound healing as well. And then the ulcers can percolate and get to a point where they don't recognize that they have something wrong, and it can lead to even gangrene and requiring amputation. Right? So what do you do? You have to know what to do to prevent that, which sounds like a good SATA question as far as how to prevent a foot ulcer from developing. They got to check it, right, every day, right, unprofessionally, and they got to check it professionally every year with a provider, right? If they have that ingrown toenail right there, do they grab the kitchen knife? No, and they're not going to try to fix it themselves. They're going to find a podiatrist to take out any kind of ingrown toenails. And of course, they have to have the Goldilocks zone of footwear. It can't be too loose and it can't be too tight, right? They have to wear their shoes at all times, indoors and outdoors. They shouldn't put lotion between the toes, but around the toes is okay. They should be washing daily. They shouldn't just put their feet into hot water, into a hot jacuzzi, and burn their feet. And now you have skin breakdown. So there's all kinds of tips and tricks to make sure they are safe with their foot cares. They don't have to require amputation. And they can go to the provider also. The provider can do what's called a monofilament test to make sure that they can feel can they feel this little wire on these 10 spots. If they can't, out of 4 or more, they have some pretty bad neuropathy. All right, so that's it for diabetes.